so much. Can you hear me, Shannon?
Yep, you're good.
Okay. So my name is Jacqueline Nunziato. Thanks for that introduction, Shannon. And I'm an obstetrician gynecologist at Carilion Clinic, Virginia Tech. I am so excited to be here today to talk about this really important topic. So today we're going to be discussing trauma-informed care in obstetrics and gynecology. And like Shannon said, please, this is such a important topic, and I know it's going to spark a lot of conversation. So I'm more than happy to take questions throughout, or we can save them to the end. But if something sparks your interest, please leave a comment or a question in the chat. So disclosures, I have none, no financial disclosures, no personal gain from the information besides being really passionate about this. I do want to say that this topic is a sensitive one, and that I will be talking about sexual abuse, childhood abuse, trauma, even encompassing kind of natural disasters. And so I know that this is a sensitive topic, and I wanted to warn everybody, if something that I say is triggering to you, we understand that. And, normally in person, I tell everybody, feel free to leave. If you have to, whatever coping mechanism you need, feel free. And we know that about this topic. And so that's what makes it so hard, even as doctors, for us to talk about. And then the other disclosure is that I want to say this has been a journey for me personally. I do not at all by any means consider myself an expert in trauma-informed care. I have recently, last summer, went to a webinar about it and then have taken several classes, but I've realized myself that in the last year, which I think COVID has been eye-opening for me, and that it's been a nice way for me to take some online classes and really gain some expertise in areas I didn't know I was even interested in. But for me, I've really changed how I practice and how I speak to my patients, and I hope that you can do the same. So, I'm constantly learning, and I know that when you hear this presentation, there will be a couple of times where you'll say, oh gosh, I do that, or because that's what I did months ago. And I still find myself sometimes falling back. It's easy to, once you hear some of the common phrases that we say, once you start thinking about how they could be portrayed by someone that's experienced trauma, you may, feel bad or feel guilty, but that's okay. That's part of the process. So we welcome that. So the objectives, I want you to be able to define trauma and PTSD, understand really the prevalence of trauma, to analyze the relationship between trauma and healthcare related outcomes, to be able to describe the principles of trauma-informed care, to learn how to incorporate trauma into your everyday practice, especially to apply trauma approaches and techniques that we give you for gynecology care and then for obstetrical care, because they're really two completely separate techniques. And then to identify resources available for you and your patients. And that's how we'll kind of wrap it up at the end. So taking it a step further, I love objectives because that's how we, get our credits for things. But I think this one really is going to take a call to action. And so I'm going to ask you to kind of do some homework when you leave. I really want you to be able to evaluate your own personal approaches to patients, because this is going to be an eye-opening, hopefully, and learning experience for all of us. Like I said, I'm still learning. It's still a journey. And I want you to be able to feel comfortable talking about these really sensitive topics. And I really also want you to appreciate the value of trauma-informed care as it relates to obstetrics and gynecology, and start today. I don't know how many of you are going back after lunch and seeing patients, but try and spend today being mindful of your conversations, your interactions, your gestures. And then the big ask is small changes make such a huge impact. I can only, speak for myself, but in the last several months of incorporating some of these techniques that I've learned, we work in a field that's positive most of the time, but something that's been so new and rewarding for me is when I have a patient that tells me, oh, you've made me feel more comfortable than any other doctor has in the past, or, I've never told any doctor about X, Y, and Z. It's very rewarding because you see that trauma really has these negative impacts on our patients. And so really small changes can make huge impacts. So keep that in mind. So definitions. According to the DSM-5, trauma is, there's no standard definition of trauma, but when you look at the DSM criteria as it meets with PTSD, individual trauma results from an event or a series of events or circumstances that experienced by an individual as a physical or emotional harm or a life-threatening event. And the importance is that it has a lasting adverse effect. And it usually affects someone's mental, physical, social, emotional, and spiritual well-being. And this is according to the SAMHSA organization, or the Substance Abuse Mental Health Services Administration, where I've gained a ton of information, a ton of statistical data, and I'll be using kind of their references throughout my presentation. And so I want you to remember these 3 E's, because the event, the actual event, the experience, and then the long-term effects of these traumatic experiences is what I want you guys to take away from this. So when you talk about traumatic events, there's really 3 types: abuse, loss, and then chronic stress. So for some reason, when I first started thinking about trauma, all I really thought about was the abuse aspect to it, where it could be emotional, domestic. It does not have to be something happening to you. It could be you witnessing something, or an adverse event or traumatic event happening to someone that you love. The new DSM-5 criteria included cyberbullying and bullying as a form of abuse, which we were very happy about. But also loss, death, abandonment, neglect, separation, accidents like motor vehicle accidents, terrorism, war. And then chronic stress. So we know, we've been talking all year about systemic racism, poverty, racism, invasive medical procedures, which we'll see will be really relevant to OBGYN, community trauma, historical trauma, family member with a substance abuse disorder, being unemployed, uninsured. All these things really affect and impact your daily life. And so they are considered a traumatic event. So it's not only that you have this traumatic event, right? But then your experience, which is so subjective. We know it's very interesting, and there's a lot of studies going on right now about resilience. 2 people can experience the same traumatic event, and what makes someone thrive and survive, and what makes someone hindered by what has happened to them, what makes there to be this kind of dose response that everybody talks about as far as affecting healthcare outcomes. And a lot of that has to do with disclosure, with feeling validated, with seeking help, and with support. And so that's really what I want everybody to kind of get out of with this conversation. So PTSD is when you experience a traumatic event and then you have physical manifestations of your mental well-being. And that could be in the form of nightmares, flashbacks, avoidance, memory loss, negative beliefs, fear, anger, guilt, reckless behavior, being hyper alert, easily scared, a lack of focus. It really affects your everyday life. A lot of times you see sleep disturbances, but really kind of a practical definition of trauma, and where I think it applies the most to us as OBGYNs, is this loss of control, right? It is something happening to you that's non-consensual, that you do not want to happen, that you automatically feel discomfort and fear, and you feel intimidated. And a lot of times you lose your bodily integrity. You feel like, something is happening to me and I don't have control over it. And that's really what trauma, even in the medical profession, is really all about. So one of the most important things is to talk about the prevalence. In the United States, one woman is beaten every 15 seconds, and one woman is forcibly raped every 6 minutes. If you think about that and you put that into numbers, by the time I finish this presentation and we answer questions in an hour, that's almost 180 women that are abused physically, and about, I'm going to do the math wrong now, about 5 or 6 women that are raped during this conversation. And so the prevalence is high, trauma is high. And until we start having conversations, frank conversations about this, then we're never going to be able to heal. And that's really what this topic is all about. So by the age of 13, at least 1 in 5 girls are sexually assaulted. As a mom of 2 girls, this number terrified me when I heard it last year. And they are sexually assaulted 1/4 or 25% by the time they're 18. Almost 70% of adults in the United States experience some type of traumatic event. And for you to put that into numbers, that's 250 million adults right now saying that they're going through some type of trauma. Those numbers do not include COVID. So I'm sure that number will be higher because in times of global distress, those numbers peak. 20% of women are raped during their lifetime. 22% report intimate partner violence. And the estimated cost, I mean, that's probably a whole nother conversation, but just to put into numbers, 120,000 up to $1 million, depending on where they are in their healthcare continuum, is the effect of one rape. And so I don't want to leave men out. 1 in 4 men experience some type of sexual violence or physical act during a lifetime. And so, it's not just physical abuse. It's not just rape. When we talk again, these numbers really break my heart as a mom. But as for child abuse, there's 3 million cases a year and 5 children are abused every day. 8% of adults, when you talk about report being abused as a child, which child abuse in this country cost $428 billion to the economy, which is, mind blowing, because a lot of this could be prevented and a lot of this could be healed with treatment and with support. This is also, a topic for another day. This is such a huge topic, but when you look at the justice system, 96% of women inmates report abuse. That's not a coincidence there. And when you look at female veterans, 80% report abuse and 41% report some type of sexual military trauma. When it comes to substance use disorder, 75% of women who are reported abuse as a child. These are patients that have the potential to get help that are not either disclosing or they're not meeting the person that can lead them to recovery. And so that's really what this conversation is about. What is the importance of something like this? So short-term consequences. So you see behavioral, emotional, and psychologic changes. We kind of talked about it before, but resisting transitions, blowing up, unexpectedly, fighting, physically fighting someone else, reverting to younger behaviors, nightmares, such a higher incidence of depression, feeling angry, sad. And the difficult and challenging part about this is they're doing it in silence. Sometimes, and we'll talk about that later, but, sometimes patients come to you and they're filled with these experiences. And if we don't try and understand where they're coming from, then we kind of just write that off, right, to poor behavior. And what we need to start doing is really asking why. Why is this patient presenting to us this way? And so one of the most important studies, and I'm sure a lot of you know this, this was actually new to me in full disclosure a couple years ago, but the ACE study is one of the most important studies that has been done. It's the adverse childhood, when it comes to trauma, adverse childhood experience study in 1995 to 1997. It enrolled 17,000 primary care patients of Kaiser Permanente. Although there was a mix of races, ages, all of these patients were insured. And so that skews the number a little bit, but the outcomes have been replicated over the years. And really what this did was it provided surveys to 17,000 patients, anonymous, to disclose trauma events. And so what they wanted to look at is, and then they looked at healthcare outcomes. And so they wanted to see what impact does traumatic events as a child play in adult healthcare outcomes, right? And so when we look at childhood adverse experiences, there's actually 3 different types. So we kind of talked a little bit about it, but there's abuse, so physical, emotional, sexual. There's neglect, which is a really high incidence of childhood trauma, physical and emotional. And then there's household dysfunction, so divorce, substance abuse, abuse towards a parent, mental health illness of either a parent or someone significant in the household, and then having an incarcerated relative. So if you look at the numbers, and we'll kind of part down more, but 1 in 6 adults experienced 4 or more types of ACEs. That's, mind blowing, especially when you see what that does to your overall life expectancy and your overall health related outcomes. And at least 5 of the top leading causes of death are actually associated with ACEs. So when you think of, cancer, anxiety, depression, cardiovascular disease, strokes, all related to ACEs. And when you look at prevention, 44% of these healthcare outcomes could have been prevented when you look at things like depression and anxiety and mental health disorders. So why is it so important as far as long-term consequences? So when I first read this, I thought, oh gosh, 1995, that was so long ago. But the study is so important that they've been able to reproduce it across the country. And these are the states that are actively involved because what we wanted to show was long-term outcomes. And so what we see is that there are a number of adverse outcomes that these patients have. So they are more likely to have traumatic brain injuries, fractures, burns, anxiety, depression, PTSD. We'll get more into the maternal health, but unintended pregnancies, complications, fetal death, HIV, STDs. If you have more than 4 ACEs, you're actually 500 times more likely to have an STD. Cancer, diabetes, obesity, risky behaviors. Again, 90% of IV drug users report more than 4 ACEs. Education opportunities, really you see a drop out in education. You see much lower socioeconomic statuses for patients as they accumulate ACEs. So think about that when we're talking about prevalence, because the chances are if you see 30 patients in a day, you're seeing many, many patients that have had traumatic experiences, and we really need to be taking that into account. And that's really what about trauma-informed care is. So when you look at kind of the step-up approach, really from conception until death, what we see is, and you'll see in the next slide, these patients are experiencing death sometimes 20 years earlier than their counterparts that have no ACEs. Because what you see is these adverse childhood experiences, and it's recurrent. It's cumulative. It's a dose effect, and you're getting disruption of neurodevelopment, of cognitive impairment, emotional, social. They're engaging in health risk behaviors, poor overall lifestyle choices. Then they get these disease burdens, and they have social problems because they lack the economic means and the support to overcome these. And so we're seeing that patients actually are dying a lot earlier. And so the dose response, so only about 1/3 of Americans can report that they don't have any trauma. And this picture to your left is the one from 1995. And the picture to the right is one of the most recent ones. And you see these numbers have not changed. In fact, they've actually gotten worse, where now more of us are reporting 4 or more ACEs, which means even though the study's been out for a long time, we're receiving the data, but we're not incorporating changes enough into our daily practices. And so for GYN specific issues, we see a lot more unintended pregnancies. We see STDs, early sexual exposures, interpersonal violence risks, and sexual violence. And so this is kind of that chart that we talked about, where if you have 6 or more ACEs, the life expectancy, instead of being 80 years, is 60 years. And so what does this mean? When we look at healthcare conditions and the things that are preventable, we see that the majority of healthcare outcomes and the effects of ACEs are preventable, especially cumulative. So for mental health disorders, 44% have the potential to be reduced. Same with economic challenges, heavy drinkers, alcohol, diabetes, cancers, stroke, COPD is a big one because it's obviously associated with smoking. So where does this move us into, right? So this is where it brings us to trauma-informed care, and why these ACEs are so important is because we've had this data for a long time, and what we're seeing is that these numbers aren't getting better. We're actually doing a lot of research, but not preventing these outcomes. And so trauma-informed care, there's not one single definition, which I like because it can be what you need it to be, how you incorporated it into your daily practice. And so really what it's about, I think sometimes it gets confused in the literature because it's not the services, right? It's not taking action or treating at the time of trauma, but it's trauma-informed care. It's how can we be sensitive to people's experiences of trauma in order to take better care of them. It would be, and it's really a shift in our mentality and a shift in our culture to treat it like any other disease, like any other medical history that we would take from these patients. It's just trickier and harder to get out of your patients or to elicit from your patients. And so it's our job to make this a safe environment that encourages choices, empowers patients, avoids re-traumatization, and so that we can join them in being part of the healing. And so when you look at the 4 traumas of informed care, the 4 R's, you look at realizing, so we've done that, right? We know the impact of trauma and we recognize, right? What are the signs? What are the symptoms? We respond. So this is a top-down approach, and a community-in approach is always my favorite, if you know me. It really takes systematic changes. It also takes community change and personal change, and they need to meet in the middle in order to take better care of patients. And then resist. Re-traumatization is so important. And when I first heard this talk, I cringed at myself because the thought of saying something to a patient when I truly have the most altruistic and do no harm intentions is devastating. That's not why I went into this field. And so I needed to take a step back personally and say, what am I doing wrong? How can I be better for my patients to avoid some of these common pitfalls? The one I really want to emphasize right now is to recognize. And that's because, again, we need to shift mentality. We've all had that difficult patient, right? They're yelling in the emergency room. They're yelling at your front desk staff. They've showed up late to several appointments. They're non-compliant. I've been saying for years, there's no such thing as a non-compliant patient. If they get here, something else is going on, and it's our job to find out what it is. The patient that's emotionally labile, the person that comes in and has a ton of complaints, but they're all vague. The patient, it's really a shift to say, this patient isn't difficult. Her life has been difficult. And when you think about things that way, you really start opening up to the possibility that you can influence change. Because dissociation is a huge coping mechanism when it comes to trauma, right? So, going blank, pretending that we don't hear you, which can be so frustrating as a provider because you think, okay, if you're not going to help yourself, how can I help you? But we can. And so hopefully by the end of this conversation, you can get some tools and tricks, and you can create a safe environment where patients want to disclose and where patients want to talk to you and feel safe in your healthcare. And so really signs and symptoms, we talked about a bunch of them, but self-blame, guilt, shame, feeling disconnected. When you re-experience trauma, And so, the dissociation part is where, from a gynecology standpoint and from a labor and delivery standpoint, this really comes into the view. So this is a kind of another approach where it's 6 guiding principles where you really just want to make the patient feel safe, be transparent, show them support, collaborate in the community, empower. You want to give patients the power that they lost in order to help avoiding re-traumatization. And then really it's a cultural change. We need to change culture. And so it's not trauma specific services. I see that in the literature, or just in common, conversation, kind of confused with trauma informed care. Trauma informed care is they've experienced the trauma. Now what? What influence can I have now that they've gone, we've moved past that. It could be childhood experiences. It could be, something from a couple of years ago, but what can we do and how does this influence their healthcare today? And so some general principles. So universal screening is key. And I know that's difficult because things you don't want to say, you don't want to come out and say, have you ever been raped? Nobody's going to disclose in that way. It's not safe. It's, jarring. It tends to re-victimize patients. What you want to do is create knowledge, educate your patients so they feel empowered to respond to you. So something like, did you know 1 in 5 women may experience sexual abuse? This is such an important topic to us. And so we want to make sure that we screen everyone that comes into the office. Have you ever experienced any unwanted sexual experiences? That's a way that I've been saying it. And one of the frustrations, and I know for everyone, a new patient comes in, the intake form is half filled out. They don't want to fill it out. And then it's like, pulling teeth, getting information from them. But it's our job as providers really to take it a step further and to figure out how we can communicate with these patients. And so since I went to, my first talk and then have taken classes throughout this year, I have been so surprised and it's been such an eye-opening experience. And I have felt, guilt myself that I haven't asked before because I've been so surprised at the amount of patients that have disclosed to me and have said, oh, no provider has ever asked me that before. And so I do it for every single patient, regardless of the visit. And I do it every single time. Consenting. So you want to consent patients anytime you do anything, touching them, asking them to, get undressed, asking them to sit down. You want to empower them. You should always ask before you do anything. I think as doctors, we're always on the go, always trying to get to the next patient. It's really important that we take a deep breath before we walk into the room, that we knock, we ask to come into the door, that they accept us into their environment, and that we take the time to explain and support and comfort them, that we offer them alternatives. One of the techniques that we'll talk about is, what do you feel comfortable with? If you don't want to, we're gynecologists, you take off all of your clothes, right? It's a unique experience, especially when you're meeting a stranger. How can we make them feel more comfortable? If you want to keep your socks and shoes on, that's great. If you want to keep your bra on, that's great. If you want to keep anything on that will make you feel comfortable, that's perfectly safe and fine. And then tell them that they can stop at any time. That's really huge. And you want to set boundaries, whether they, if you have anxiety, if you are nervous, let me know and I'll stop immediately. And then jokingly, but not, we have to stay in our lane. I think that's so hard sometimes as providers because you can't fix everything. And you don't want to elicit too many details about their traumatic experience because that's not what this visit is about. The visit is about how can you be aware of their experiences, learn from their experiences, and use that information to take better care of your patients. And so, timing is everything. If it's something that happened a long time ago, you just need to know about the information and then you need to ask them questions. What can I do? Have you had experiences in the past where the pelvic exam has been uncomfortable for you? Do you have any suggestions that would make you feel more comfortable? And then always, always, always have your resources available. If you're going to ask these questions, you need to be prepared to give your patients the answers that they need, right? So you need to have referrals in place. You need to have a good support system. You need to have a good staff, and you need to be able to tell patients where to go when they finally do ask you for help. So ACOG recently came out with a committee opinion, which is a change from their one a couple of years ago. And it's really about caring for patients who have experienced trauma. And what I like about it is they talk to providers specifically about what you can do, tools that you need, because you need to be able to give patients, survivors, a sense of control. Physical and emotional safety is very hard to establish when you're first meeting a patient. And so, you know what? It may be okay that you don't have them get undressed the first visit. Maybe you just want to take their history, establish a rapport, and have them come back. That's okay. You always want to stay calm. You always want to contain yourself. You want to show care and empathy and sympathy, if that means giving them a tissue. You always want to remember your coping skills. You want to show them strength and resilience and hope and be a part of their healing process. So how can we incorporate trauma-informed care into GYN care? I think for me, one of the big things, and I know this is so much easier said than done, but in the healthcare system that we have right now, where we're just see another patient, see another patient, see another patient, it's so hard sometimes to stick to your principles of not getting the patient undressed before you meet them. We don't want to be naked and exposed and feel vulnerable in front of a stranger either. And neither do your patients. They want to meet you. They want to, they've been waiting sometimes weeks, months to meet with you, to talk to you about what's going on. And so you really want to meet them on equal footing, and you being fully dressed in your white coat, or if you don't wear a white coat, and meeting them naked is not evening, is not meeting them in an environment that's safe. So you really want to establish a rapport. You want to set goals. I ask patients this all the time after I elicit a history. I say, what's your goal for today's visit? What do you want out of this? Inquire about their fears. So I, as a gynecologist, I always ask, have you had any negative experiences in the past with your visits? And what do you think that I could do better to make that experience for you today better? Or I'll ask them, what was a difficult part of the exam? And I'm always surprised. Sometimes it's just, I don't like having my back exposed, and I don't like having my front exposed. So I've told patients, okay, you can put 2 gowns on. That's absolutely fine. I always assume that it's the pelvic exam, but it's not. Sometimes it's just sitting there, or talking about a sexual history. And so ask your patients, because they're pretty in tune with what they feel comfortable with and what they don't. And then give them options. Again, gown in the front, gown in the back. Do you want to keep your, shorts on? Do you want to keep your shoes on? I do ask all of my patients if they have a preference. And if it's their first gynecology exam, I show them the difference between a Peterson and a Graves. And I tell them, the Peterson is long and narrow. If you, have not had much sexual experience, if you haven't had children, I think this will work for you a little bit better, and be willing to go through more than one speculum if that's what it takes. Instead of placing patients' feet in footrests, you can frog leg them, knees out to the side if they feel more comfortable. They can self-insert a speculum. When I first heard this, I thought, nobody's going to want to do that. But you would be surprised, because patients are intrigued and they want to know and be educated about themselves. Most patients don't hear about their womanly reproductive organs outside of grade school when they are, taught sex education. And so since I've been incorporating this, they love learning about themselves. And so I actually do offer them a mirror too. And they like seeing what's down there, because some of them aren't capable of looking. Some of them are scared to look. Some of them fear looking, and some of them just don't know what they're looking at. And so if you don't have to use a large Graves, please don't. Patients really often report Patients with ACEs and report of 3 or more report really, really negative experiences with the pelvic exam. And so please be mindful of that. And then be mindful of the words you use. So this was huge for me because, you get into your routine of what you say to patients, but I never, or, every once in a while, I never say bed anymore. I say table. I don't ever tell patients to relax because that's often when you look at trauma experiences, especially sexual and physical abuse, or even a traumatic event or a motor vehicle accident, things that people say in that moment are relax, 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 relax. And it's meant to be a coping mechanism, but it can trigger patients. So I tell patients instead, try and breathe with your belly, belly breathe. Think about yourself kind of, you know, um, falling into the table. I use the word drape instead of sheets. I've been trying really hard not to say stirrups. Instead, I say foot reps, right? Because foot rests, because stirrups have this like animal kind of connotation to it. Again, avoid, relax. I mean, I know that, and when I heard this, I thought, oh my gosh, I know I've done this before in order to help patients, but how traumatizing can it be if I'm the person that is trying to open their legs, even in labor, and we'll talk about that. But you want to avoid making any gestures where you're trying to spread their legs. Instead, I now say, like, when you're ready, let your legs fall to the side, meet my hands on the side. And so I put my hands to the side. You don't want to say things like, the more are still, the sooner it will be over. That's actually a common phrase for physical and sexual abuse. Things like, you've had children already, you should be used to this, or you've had a number of partners, this should be no big deal. Things you should never say. There is a huge difference between consensual, intimate experiences and non-consensual. And when you tell patients things like that, it re-traumatizes them. And then using grounding techniques are so important when you are done with the exam. So one of the other things that I didn't mention, sorry about that, but it's really important that you have these conversations before patients get undressed. Tell them about the exam. So I love seeing a patient that's new, that's never had a gynecology exam, because I do a ton of education and I show them the speculum, I pull out the footrest, I tell them they're going to be on the table, because you want to be the person that educates them, right? In this day and age, you don't want them going on TikTok. You don't want them, texting their friends. You want them to get it from the most reliable source, right? Because you want them to feel safe in your presence, and you want them to trust you. So when you're done the exam, make sure you give them, communication is key. Make sure you ask for feedback. Is there anything that I could have done better? Debrief with them. Tell them what you saw. An interesting study came out last year in Sweden, where they looked at thousands of women after their annual visit, and their perception of what happened versus what happened, meaning, did they get a pelvic exam? Did they get a pap smear? As far down as being able to label the vulva versus the vagina, patients do not know what you're doing. And so if you take the time to educate them, they feel empowered. And then come up with a plan. That same study showed that they often leave feeling like there is no plan in place. And so we'll skip over quickly to trauma-informed obstetrical care. So, when you find out you're pregnant, or you find out your patients are pregnant, the first thing everybody says to you is congratulations, right? Congratulations. It's full of rainbows and butterflies and sunshine, and the pregnancy is beautiful and perfect. But this is a society expectation that we place not only on ourselves, but as providers, but patients on each other. And for someone that has experienced ACEs, can you imagine what this must feel like? So an average of 14 visits, you're talking about somebody that has completely avoided the healthcare system. And then a loss of control of your body. Pregnancy, if you've been pregnant before, it's almost like an out-of-body experience. You don't know yourself. Fear, anxiety, pain. And so by the time you deliver, some patients report being 400 times more likely to experience anxiety, depression. These patients sometimes don't want to disclose that they don't want to be pregnant anymore, that they are having fear and anxiety about being new moms. So there is a huge difference between a traumatic birth experience and obstetrical violence. And I really want to spend just a quick moment kind of discussing the difference. So there are outcomes that we are unexpected, right? The non-reassuring fetal heart tracing that turns into a stat C-section. A neonatal emergency, you have a baby that comes out that should be coming out with APGARs of 9 and 9, perfect score, and they come out floppy and they're taken over to the resuscitation by the NICU team. Those are unexpected outcomes. And I can tell you, from firsthand experience, I didn't even think of my experience this way, but, I had an emergency stat C-section myself with my daughter, and I delivered early. And looking back on it, yes, it was a traumatic experience. And as an obstetrician, I love the stat C-section because the adrenaline's rushing. You want to fix the problem, how, and when you have good outcomes, that's how you feel as a provider. But think about how patients feel. Often I have patients come back and tell me they don't want to get pregnant again because of those experiences. And so it's really important at those postpartum visits that we address those moments, like the non-reassuring fetal heart tracings. It's our job to talk to patients about what that actually means. And then that's different from obstetrical violence, which is so, so important right now and is talked about so much in society and so much right now, even in social media. But that is really getting a loss of autonomy and patients feeling like their autonomy has been taken from them by their healthcare provider team. So repeated unnecessary exams, unindicated episiotomies, activity and food restrictions. You can't get out of bed. You need to be restrained in this, you have to wear this hospital gown. You need this, you need to take this medication. And then differences in treatment. We all know, there's been many studies that have showed race, gender, patients with substance disorders, they have gotten treated differently by us, and it's time for change. And so this is known as obstetrical violence, and it's considered a traumatic event. And so how can we help? So we want to come up with plans early, right? I hate the birth plan, but I love birth preferences, right? And the only reason I don't like a birth plan, and it's not an eye roll, which I hate when I see other providers or when I see nurses or hospital staff or even other moms eye rolling other moms when it comes to their birth plan, but more preferences. And we should be able to listen to this, and value and respect patients when they tell us what their preferences are, because they do have the right to choose, and that makes them feel empowered. That makes them feel like we're making shared decisions. And then informed consent. It's so important to talk to patients about all the things that can potentially happen before they come in for labor and delivery. I hate that patients feel so traumatized by these unexpected outcomes because they don't know they exist. It may seem silly to consent them early, but don't we do that for every other procedure? I mean, we would never take anybody to the operating room without telling them all of the potential things that can happen. And there are negative outcomes that can happen, and we need to talk to patients about that. We also want to talk to them about what are their concerns, what are their desired outcomes, and we want to brainstorm ideas with them. And so this will take a culture change, right? From a patient perspective, we want to get rid of the eye rolling when it comes to plans, doulas, extra support. Like, who are we to say things like that to patients? Of course, they can have the support they need. Of course, they can make decisions. It can be shared decisions. And I think where the disconnect is that we need to educate them, to talk to them about what they've heard their birth plans are, what they've heard their expectations are, and we need to meet them in the middle, because it's hard. There's shift changes, revolving doors, invasive procedures, restraints. And it's really our opportunity to educate, to collaborate, to communicate better, and to empower your patients. And so that's really the key to trauma-informed care. And then finally, resources. So I'll kind of end things with that, because I know we'll probably have questions, but know your resources. I put a bunch of resources up. So in this area, We have the Sarah Foundation, TAP, DADS, so domestic abuse disruption, which has helped over 1,000 women get out of their home during COVID. We have the Virginia Sexual and Domestic Violence Action Alliance. We have all these references here. And so please, I can send this to whomever wants this information, but we have community nonprofits that are working very hard to help close these gaps. And so, hopefully by the end of this presentation, you will have been able to answer all of these questions. And I'll just kind of end with one kind of final thought is, these patients, often when they do come to us, especially pregnant patients, right, because they have a reason to come, they love and care for their baby. Sometimes they come to us at the end of their ropes. And we as healthcare providers can choose to cut that tie, right? They never get care with us again. Or we can bridge that, right? We can tie it together. We can, you don't necessarily have to make a heart, but we can strengthen their connection to the healthcare system in order to change outcomes. And so I really challenge you to take this information and really self-reflect and kind of evaluate what you're doing to help patients. And then these are a couple of good resources. Again, I could send this to patients, but you can earn your, this is something I may do. It's kind of, one of the advantages of not having in-person conferences is that you can take, I've gotten a couple of certifications last year. And so the Crisis Prevention Institute is perfect. If you have not read these 2 books, please, please, please do so. It will enlighten you. It will open your eyes, and it will 100% change the way you interact with patients on an everyday basis. And then these are my references.
Excellent. Thank you very much. We have some questions for you. So the first one, will the slides be available?
Sure. Yep.
I'll send them out to everybody. And then on another question from Crystal, on average, how many patients do you see a day, and how much time do you typically spend with each patient?
Yeah, that's a great question. So, in full disclosure, you could ask my patients, I'm always behind, and I'm usually behind 20, 30 minutes on average. And I will tell you, and I think my office staff, hopefully they're outside, I'm seeing patients today, can tell you that when I am late and I make it worth their while, no one tells me they don't want to see me again, because they want to spend time with you. I see anywhere, it really depends on the day, but between 20 and 25 patients a day. I know in private practice, you see more. Shannon and I are working on the 4th trimester AIM. I am a huge proponent of taking advantage of every single prenatal visit, every single one, right? You can take, that's a visit where you have 10 or 15 minutes, use that, get to know your patients, ask them those pertinent questions. They don't need to disclose to you the first time, but I kind of do my own Edinburgh in the second into the 3rd trimester, because I know how much anxiety peaks. And so I take that opportunity to say, like, what's the plan? Postpartum Support Virginia has an amazing worksheet that I think is a more realistic expectation of how you can plan things to better prepare yourself. And so I give that to patients usually around 27 weeks. So now, am I known to spend a long time with patients? Yeah. Usually what I'll do is I'll start to talk with a patient. I'll spend an amount of time, and I tell my nurses or my CNAs to room multiple patients, and I'll pop back and forth, and patients don't mind at all. They want the time. And now I bill according to time. So that's nice.
All right. Thank you. Anybody else have any other questions? If you do, because I can't see the hand raise, if you do, can you put them in the chat, please?
And I can include, before I send my slides to Shannon, I can include my email address. And if you have any questions and you don't, I know that this is such an important topic and I know it's so sensitive. And if you don't feel comfortable chatting, you can send me an email. I can also include my phone number. I am a huge advocate of just resource gathering. And so also if you have any resources that I didn't mention that you want to share, please feel free. The CDC and SAMHSA have just amazing resources for patients, for providers to hand out to their patients. A lot of graphical information that I think is wonderful too.
All right. Just thank you very much. This is a wonderful presentation. And other than that, I will not keep everybody because I know
Okay.
this is lunchtime. But as was mentioned, I will include email addresses and presentations so we can, and if you want, you can also email me and I can make sure we get an answer. So without further ado, thank you everybody for participating.